As you can see, the anaesthetic chart holds a vast amount of information. So going through the chart, if you start with area 1, we can see the details of the anaesthetic given, namely a general anaesthetic or a spinal anaesthetic, often used in our fractured neck of femur patients who may not be fit for a general anaesthetic. Remember, the important thing to note here is that with spinal and regional anaesthesia, we normally expect this to work for about 6 hours. So as the doctors post-operatively, if you start to find that the patient begins to experience pain around this time, it's probably because their anaesthetic is wearing off, and it's always good to preempt this pain.
The back of the chart is an area for the anaesthetist to write any specific requests. Sometimes it might be something simple such as please do a full blood count post-operatively on the ward. For example, a gas might have shown a lower HB and blood's being given, so you just need a formal count to make sure we're back in the normal range. And if a patient has been struggling with urine output during the operation and is undergoing fluid resuscitation, again, we may mention to keep an eye out on that. This is where we prescribe our medications. So in this whole area is all our drug prescribing. Specifically, you can be looking out for things such as opioid use. We often use fentanyl and morphine. Obviously, the higher doses we require, the more painful the surgery was. So again, this is something to bear in mind with post-operative analgesia. But also, the more opioid medications we use, the higher the risk of post-operative delirium, especially in our older patients. Vasopressors used in anesthesia are namely metaraminol, which is an alpha-1 agonist, or ephedrine, which is an alpha-1 and beta-1 agonist. So if you see lots of these two drugs used, or one of them being used a lot, then would be a sign that there was some instability intraoperatively from a cardiovascular perspective. The other thing to think about is if someone's had a spinal anesthetic, the spinal anesthetic, depending on how high it goes, there are sympathetic nerve fibers in the T1 to T4 region. So if we get a higher spinal anesthetic, this can also cause hypotension. So sometimes a metaraminol infusion can be used to counteract this. This is where we sometimes handwrite our observations, or more and more commonly now, we print out the observations and stick them in the chart. Really, you'll be looking at things such as low blood pressure during the operation, so periods of intraoperative hypotension. The causes of that can be varied, things such as blood loss, reduced cardiac contractility, as well as the fact general anesthetic in the form of volatile agents, what the patient breathes in to stay asleep, that itself has a direct influence on cardiac output and reduces the blood pressure by causing a vasodilation. So all of these things can be leading to intraoperative hypotension. The important thing really is the duration of this, specifically keeping in mind that some patients post-operatively may have AKI, and one of the causes of this can obviously be pre-renal in the form of hypotension. So again, that's something to look out for. Similarly, in the observation area, you'll also notice that there's heart rate included. Sometimes we can get episodes of bradycardia intraoperatively, so we're thinking about things like, is the patient beta blocked? Do they have a permanent pacemaker? Was there vagal stimulation that causes this to happen? So that's something else you can learn from the anaesthetic chart. On the other end of things, they can go tachycardic. Often this can be a sympathetic nervous response to pain, but also they can go into rhythms such as AF, and the way really to work this out is if we are using any antiarrhythmic drugs intraoperatively. So if you see anything like amiodarone or digoxin being used, magnesium is the other one we use often, that may indicate that the patient went into a fast AF, and again is important for you to know post-operatively. We usually treat intraoperative bradycardia with things such as glycopyrrolate or atropine. This is where we write down our IV fluid, so often this will be Hartmann's, that's our normal fluid that we use, but it also can include things such as high percentage glucose, which again would give an indication that they might have intraoperative hypoglycemia, but also this is where we include all our blood products, be that pat red cells, platelets, FFP, cryo. It will all be included in this area. Then we move on to where we usually give a rough idea of total fluid in, and often if they have a catheter, the patients there will be an area for urine output where we will give an idea of how good their urine output's been and document that as well accordingly.